Good evening, everybody, and welcome to our 17th annual Peter Meese Lecture. It is my privilege to welcome you all here today, and I'd just like to mention a few special guests. Our Chair of the Cabrini Board, Mr Richard Rogers, is here with us today. Dr Darren Lockie and family. Dawn Adams, who's a patient of Peter's, who saw the sign and decided that she better come tonight. Very much appreciate you coming. And of course members of Peter's family as well, and members of our community and the Cabrini community. Thank you so much for attending tonight. I'd like to hand over and invite Dr Michael Walsh, our Chief Executive, for the acknowledgement of country.
Thank you, Lee, and good evening, ladies and gentlemen. It's great to be here for the Peter Meese Memorial Lecture. I would like to acknowledge the traditional owners. So this event is being held on the traditional lands of the Wurundjeri people, and I wish to acknowledge them as traditional owners. I would also like to pay my respect to their elders past and present. Allow me to take the opportunity on behalf of Cabrini to welcome Dr Darren Lockie, who's been here 17 times now in this.
Yes.
So it's a fantastic effort, and members of the Lockie and Meese families, past patients and friends of Peter Meese, university partners, donors, Cabrini colleagues and supporters of Cabrini and of the Meese Memorial. I'd like to point out that this is the 17th anniversary of the event, so it's become a part of the Cabrini calendar, and it's I think a terrific achievement and a great memorial to Dr Meese. I'd also like to welcome and acknowledge our keynote speaker for the evening, Associate Professor Susan Lee, and it's great that you have given of your time to come and speak to us tonight about person and family-centred care, which is an incredibly relevant topic in today's healthcare system, and in particular in the private healthcare system, where I think increasingly questions are being asked about how we provide value for private health insurance and private health, and so this is an incredibly relevant topic, so thank you for taking the time. I will now hand back to Lee, who will take us through proceedings.
Thank you. Thank you. It's my privilege to start the evening by welcoming Dr Darren Lockie, who is the Director and Chief Radiologist at Maroondah Breast Care Eastern Health and Consultant Specialist at Monash Breast Screen. His professional focus is obviously breast imaging and the early detection of breast cancer, so very strong links with the theme from today. Long-standing relationship with Cabrini as a practitioner, a carer, family member and now donor of study scholarships, something that has a huge impact on our staff at Cabrini. Research grants, he supports us in a number of our research endeavours in regards to oncology research, particularly in nursing, and founder of this fabulous annual Peter Meese Memorial Lecture. I now invite Darren to say a few words.
Thank you, Lee and Michael, for your acknowledgement of the traditional owners and for your warm welcome to everyone here tonight for this, really, which is a packed out 2018 Peter Meese Memorial Lecture. The RSVPs have been amazing and really from a diverse cross-section of the community and the health sector. It's a tribute to our speaker tonight, Associate Professor Susan Lee, and her theme of centred care that have drawn in tonight's audience. It is always a pleasure for me to see family and friends, staff and patients of Cabrini Executive of the hospital and elsewhere. But most importantly, it's important for me to see nurses in the audience, because this event is about you and for you. 18 years ago, Peter died from bowel cancer. A year before that marked the beginning of his cancer journey and our association with Cabrini. It started with the diagnosis of liver cancer with no known source of the cancer origin. It was one of those literal blink of an eye moments. From that began the roller coaster year of appointments, tests, surgery, chemotherapy, radiotherapy. And one by one, the cancer treatments failed and ultimately options dwindled until there were finally none. But there were always the generous, friendly, inclusive, holistic care from all of the nurses that we came into contact. The nurses that not only cared for Peter, but they also cared for both of us, and in the end they cared for me. Peter felt like a person and not a patient. I was cared for as a carer, and we were acknowledged and treated as partners long before equality was on the social agenda. Cabrini nurses translated compassionate care into reality. And that was an amazing and empowering experience for me, one with a lasting legacy. That it still delivers for my professional desire to deliver focused care every day of my working life. So I'm sure I will pick up some new tricks and approaches from Susan's presentation a little later. But this lecture and the grants are to acknowledge all of the nurses involved in all aspects of cancer care across Cabrini, and to affirm their enormous contribution to not only patients' wellbeing, but also to their family and to their carers. It's my thank you to all of you for that wonderful, compassionate care and support you gave to Peter and me. Susan's topic of person and family-centred care, what does it really mean, taps into my desire for nurses to lead in this area of patient wellbeing, so that all patients and their families and carers can experience the wonderful care that both Peter and I received. So applications are now open for the Peter Meese Memorial Oncology Nursing Research Grant, which is rather a mouthful. There is $15,000 available to support nurses in building their oncology research capacity, whilst also incorporating with members of a multidisciplinary team. The aim is that the lead researcher is a nurse. It is multidisciplinary, including at least one other discipline. It is an oncology-based research project. You can work at any of the Cabrini sites. It's also the only nurse-led research opportunity at Cabrini. So I say, go for it. And see Michelle Tonkin tonight for more details. And if you want, we could even collaborate or consider collaboration with Maroondah Breast Screen, because I think there would be some great research opportunities. Now, this is the best bit for me. It always gives me great pleasure to announce the recipients of this year's Peter Meese Travel Scholarship. This year it is to be shared by two rising star oncology registered nurses, Candice Lonock and Stefan Poulouse. Candice is from the Melbourne Day Oncology Service and Stefan is from Force South. These are two high-performing nurses and they will visit the Chris O'Brien Lifehouse Cancer Centre in Sydney next month, and they'll be able to conduct this is the quote from the official sources, gap analysis and benchmarking. They'll observe and gather information around Lifehouse's workflow policies and processes, risk management strategies, workforce constructs, qualification scoping and opportunities for collaboration. And the most important thing really is they have the opportunity to network and exchange ideas with colleagues in other institutions, and that is invaluable. So congratulations to Candice and to Stefan, and if you'd like to come up, I'll...
one job at the beginning and I forgot it. So the housekeeping is, the exits are here. There's a door through there that will take you to the ladies and gents, and if we need to exit, please go there, turn left at the end of the corridor and go down the stairs, and there's an exit pathway from there. Sorry about that. Okay, it is now my absolute pleasure to introduce you to Associate Professor Susan Lee. Susan has have we got our, there she is. Susan is Director of Research Degrees for Nursing and Midwifery at Monash University. She has a really strong affiliation with Cabrini, and that's a picture of her on the Cabrini pilgrimage with her husband on their honeymoon. So that's pretty dedicated, isn't it? Yes, they spent their entire honeymoon on the Cabrini pilgrimage in Codogno in Italy. I also have a very strong personal connection to Susan. She taught me as an undergraduate student and also in some of my postgraduate studies, and I've worked with her as a colleague at Monash University, and it has been my absolute pleasure to do so. Susan is a foundation member of Monash University's Palliative Care Research Team. Almost 25 years ago today, she was there in Codogno doing wonderful things and learning about the Cabrini sisters. She has a Master of Bioethics and a PhD in nursing, all related around palliative care. Her research has spanned a wide range of palliative and end-of-life care issues. However, her particular focus is on health professional relationships for building decision-making. Can you please join me in welcoming Susan to the podium?
Well, that photo takes me back. It was a really, really wonderful trip, and Lee's quite correct. We've had a very long association, but it does make me feel rather old. Nevertheless. I'm also going to start by acknowledging the traditional owners of the land on which we are meeting, the Wurundjeri people. I pay my respects to their elders past and present, and the elders from other communities who may be here today. I would like to thank Lee and Dr Walsh for that kind introduction, and particularly Cabrini Institute and Cabrini Health, the Meese family, for inviting me here today to talk about person and family-centred care. I'm particularly honoured to be talking about things that I'm passionate about, and that always makes the task a little easier. Over the years, I've realised that we're not all health professionals, just health professionals, or patients or family members. As time passes, all health professionals inevitably become patients, and many times are family members of a patient. So it is with vested interests that we all get concerned about person and family-centred care. One of the most important outputs of the relationship between health professionals and patient and family are healthcare decisions. Today I want to talk about person and family-centred care from the perspective of that relationship and the healthcare decision-making. In particular, I'd like to talk about shared decision-making. I'm not going to sugarcoat it though. Not everyone has an experience that we've heard about just earlier. In clinical practice and in life, shared decision-making, person and family-centred care tend to be messy, difficult, and we, patients, family members and health professionals, are not all good at it. We don't always agree, and that makes it hard work. So I also want to talk about my other areas of interest: education, skill development, and working with substitute decision makers. I'm essentially a qualitative researcher. I'm interested in experiences and what we can learn from those experiences. The narrative experiences I have gathered from patients, family members and health professionals are not exhaustive descriptions, nor are they generalisable to all patients, families or health professionals. but they do help to illustrate and provide meaning to some of those concepts. So I'm going to start by introducing you to a family. No person or family is particularly typical. We're all individuals. So the Bath family is not typical, but starts with John, his wife Stella, and their 2 children, Barbara and John Jr., who don't live with their parents. This family are not real, but reflect the experiences of my research participants in clinical practice. I will elaborate and develop their characteristics as we proceed. They look Asian, but I've given them anglicised names. They could just as easily be Southeast Asian, Eastern or Southern European, Middle Eastern, North American or 4th generation Australian. This family and all of their possibilities will assist me to explore some of the challenges and nuances associated with patient and family-centred care. In the latter decade of last century and early 21st century, dissatisfaction among patients regarding their healthcare experiences was a major driver for the development of models of care which centre on the recipients of care. Person and family-centred care are not new or controversial topics. They have been an accepted part of healthcare practice for decades across the world, at least the last decade in Australia. Definitions of person and family-centred care abound in the literature, and so I have chosen an Australian one from the Institute of Patient and Family-Centred Care. Patient and family-centred care is an approach to the planning, delivery and evaluation of healthcare that is grounded in mutually beneficial partnerships among healthcare providers, patients and families. In an impressive overview of 46 reviews on person-centred care, Sharma and colleagues sought to shed some light on the elements of person-centred care. She found that there were 6 components of person-centred care, including establishment of a therapeutic relationship, shared power and responsibility, getting to know the person and empowering them, trust and respect for the person as an individual, and communication with the person. She emphasised that a key finding of the review was the inclusion of family as an integral part of person-centred care, and it was imperative for professionals to get to know the family and consider both person and family as the centre of care. The basis of this partnership is a fundamental respect for human dignity, a respect for the right of a person to make decisions for him or herself. In healthcare in Australia, it forms part of the standard for partnering with consumers, one of the National Safety and Quality Healthcare Standards, which states that at the level of the individual, partnerships relate to the interaction between clinicians and patients when care is provided. At this level, a partnership involves providing care that is respectful, sharing information in an ongoing way, working with patients, carers and families to make decisions and plan care, and supporting and encouraging patients in their own care. Numerous studies across the developed world have demonstrated the benefits of person and family-centred care. The Australian Commission on Safety and Quality in Healthcare summarises the benefit of person-centred care in these ways. When you receive person-centred care, your care will be focused on your quality of life. From your perspective, you are less likely to receive interventions you don't want. You're more likely to be satisfied with the care you receive. You are less likely to require readmissions to hospital due to a hospital-acquired infection. You're more likely to adhere to the instructions that you're given about your medication or other health maintenance activities. Your functional health is likely to be better. Health professionals who practice person-centred care are more satisfied with their work, and family members in the community are more satisfied with care providers. But here is the most significant reason why governments and health providers have to treat person and family-centred care with great attention. It reduces healthcare costs and costs to the community. Think about it. By putting the patient's needs at the centre, More satisfaction might mean that they don't shop around for multiple opinions. Less readmissions makes beds available for others. Adherence and improvement in functional health gets people back to work more quickly. The benefits to patients, families and the community of person-centred care are significant. So patient and family-centred care are a good basis for healthcare decision-making. Shared decision-making is the instrument by which we exercise patient and family-centred care. Because of this, I'm going to focus quite a lot on shared decision-making. Shared decision-making is a consultation process where clinician and patient jointly participate in making a health decision, having discussed the options and their benefits and harms, and having considered the patient's values, preferences and circumstances. This definition is from a paper in 2014. However, the research about this consultative process came from the consumerist movement back in the 1970s, and research on collaborative decision-making in health goes back to late 1980s and 1990s. Let me explain by introducing you to a case derived from my research. If we go back to the Bath family and their first brush with cancer, Stella has had a lump in her breast investigated and has been sent to her GP, by her GP, to a surgeon who diagnosed breast cancer. She has attended the consultation on her own as her husband is at work and her daughter in class at university. Stella is offered 2 treatments with similar outcomes in relation to prognosis: mastectomy with sentinel node biopsy, or a breast-conserving option of lumpectomy, sentinel node biopsy and follow-up radiotherapy. Before she leaves the surgeon's rooms, she is booked for the surgery the following week and signs a consent form for a mastectomy. On reflection about this consultation, she said, "He was so matter-of-fact and brusque. It wasn't really an option, as the radiotherapy was 6 weeks. John needs the car. It all happened so fast and my head was in a whirl." Now, before the nurses in the room tut-tut about the lack of a breast care nurse involvement, sadly, being a nurse does not ensure that you'll get this right either. There are all sorts of reasons why a consultation might be perceived like this. Just as I heard from patients that some doctors were brusque in the decision-making and personal, I also heard that some nurses didn't listen and were too busy to engage in discussion about decisions. But more about this later too. I want to focus on Stella and what role she was expecting to take in the decision about her care. If you've ever been in Stella's shoes, you may recall feeling just as she did. The decision-making required during a diagnostic and staging process is relentless. It appears on the surface that Stella may have felt pushed into making a decision. In my PhD some years ago, I came across a tool developed to determine the preferred decision style. It is a simple set of cards used to determine a person's preferences for the way in which they make decisions about their care. You could substitute nurse, physiotherapist, radiographer, or any other health professional for a doctor here, and the role cards still work appropriately in identifying the way in which a person prefers to engage in care decision making. In the original design of the tool, people sort the cards from most to least preferred style. In the original research, the authors found that when people were really sick, most preferred a passive role, D or E on this list, and when well, a more active role, A or B. However, if unable to be involved because of illness, most people, patients and members of the public, expected health professionals to collaborate in decisions about them with their family. A slightly later study by Kinterbeaver and colleagues in the UK in 1996, specifically with 150 women newly diagnosed with breast cancer, also indicated that they would prefer a more passive role than 200 women with benign breast disease who preferred a more collaborative role. You might be thinking that these studies both use specific cancer populations and might not be applied more broadly, And also, they're quite old. You may be correct. So let's turn to a more modern study then. A 2017 publication of 2014 data from the USA Health Information National Trends Survey. This was over 3,600 respondents. They filtered for people with a cancer diagnosis, but who without a cancer diagnosis, but who had had at least one visit to a health provider, and examined the responses to questions about treatment preferences for a hypothetical cancer diagnosis. They used the same decision-making role preference scale that I've just talked about. Despite some missing data, I think this is more powerful than the previous reports of decision role preferences because it's more recent and because it has a larger multicultural sample. The study reported by Spooner and colleagues found that if participants had a moderate chance of survival from their hypothetical cancer, if you look at the outer ring here, so it's a moderate chance of survival, they would have a preference for collaborative decision making. It's the orange part. However, if their chances of survival were low, they would prefer a more active role. In the middle here. In this study, the number of participants who preferred a more passive role was less than 8%. This is a very small group, and there were some interesting findings related to ethnicity and education, but I'll return to this later. So what we can gain from this is that the more people have to lose, the more say they want in their healthcare decisions. And before you suggest that shared decision making is time consuming and it makes people anxious, the research on this suggests otherwise too. In an excellent review of some of the issues associated with shared decision making by Tammy Hoffman and colleagues and published in the Medical Journal of Australia, they suggested that the misconceptions about shared decision making are hampering implementation. In the paper, this list of common misconceptions is refuted with an extensive research findings from the past 2 decades. 3 systematic reviews indicated that there is no systematic increase in consultation duration if shared decision making interventions are used. Secondly, shared decision-making is a collaborative process where the patient is not solely responsible for the decision. It is a participative process. Since the year 2000, most studies, that is 71% of studies, report greater than 70% of participants preferring a role in shared decision-making. Shared decision-making skills can be learned by clinicians and patients increasingly. Studies demonstrate successful implementation in clinical practice. Vulnerable people may be less able to engage in shared decision-making because of poor health literacy. Studies have demonstrated that they receive less information, ask fewer questions, and are less satisfied. However, self-efficacy is modifiable. We have an obligation to reduce inequity by doing more to engage the most vulnerable in making informed decisions. Indeed, it may be that Stella was a vulnerable woman whose first language is not English and as such may also have less understanding of healthcare systems and processes in Australia. A review of 33 observational studies of patient involvement found low levels of patient-involving behaviours. Another systematic review of barriers suggested clinicians lack familiarity with shared decision-making. A Cochrane review of decision aids found no effect of those decision aids on anxiety, and Hoffman suggested that anxiety shouldn't be confused with decisional conflict, which arises when considering the pros and cons of different options. So, person-centred care and family-centred care is dependent on shared decision-making. Shared decision-making is an expected standard of health services because it produces positive outcomes. Most people want to and expect to collaborate or share decision-making with health professionals. And shared decision-making is likely efficient and effective, does not place a burden on patients and families, and does not increase patient anxiety. So what does that tell us about Stella and her dissatisfaction with decision-making? How did person-centred care fail here? If she preferred a more collaborative role, why did it happen? I was particularly interested in the elements that ensure that people are involved in decisions about their care, and I asked them to use that role card sort to explain to me what happened to them. As it turned out, most of the patients I interviewed had a general preference for collaborative decision-making, but would resort to active decision-making, sought second opinions, advice from less qualified professionals, or just ignored advice if the conditions about their health professional were not met during the first consultation. Stella has already alluded to it. It was the manner, approach, sense of consideration for her particular circumstances that made her feel that the decision that was made might not have been the right one. Not really hers, or at least the process was less than satisfying. Some years ago, when I was grappling with what all this meant, I was with my mother and siblings in an emergency department while Mum was pretty ill, talking about how nice the registrar was. It made me think about what we really meant by nice. As patients, is that all we're concerned about? Not expertise or qualifications, but just nice? Could being nice mean that a patient would be swayed to make decisions a health professional advise and be less critical of those options in relation to their own values? Aranda and Street wrote a critical exploration of nurse-patient interactions, arguing that nurses and patients choosing to reveal aspects of themselves in response to interactions, that nurses would in effect try to fit in order to gather information they needed for decision-making. She emphasised the mutual construction of the relationship. Later, Aranda wrote an editorial for the International Journal of Palliative Nursing, warning palliative care nurses that there were risks in relying on being nice. She suggested niceness was a veneer that lulls nurses into a false sense of patient satisfaction with a warm and fuzzy feeling of being helpful. Street was equally critical of workplace cultures where niceness acts as a veneer of civility and created reluctance to challenge practices and critique the work of the team. So the risk might be for a patient and a family that if the relationship is based on niceness, they might not be comfortable saying that they've not complied with the advice given. They may fear abandonment or loss of the relationship, so the health professional is then making further decisions on the basis of false information. So person and family-centred care and shared decision-making should not just be a matter of being nice. However, I'm not suggesting that health professionals should not be nice. In my study of involvement in decision-making, I interviewed experienced patients with long-term illness. Most of them were in the last 6 months of their life. I also interviewed their family members and their health professionals. What the patients told me was reinforced by the family members and health professionals. Relationships with health professionals where patients could be involved in decision-making were ones where the health professionals made the patient feel welcomed, introduced themselves, asked questions about the person and found common ground, interest in a book or a television show, interest in hobbies, those sorts of things. The health professionals asked questions about their needs and issues, but came prepared, having read the history or a referral letter. So there was a sense that this health professional knew about the patient. Kindness and gentleness was talked about as an explanation of caring. The provision of timely, understandable information, all these things led to patients and their family members feeling that they could trust the health professional sufficiently to involve them in decisions about their care. and yes, I am suggesting, that patients attempted to control decision making if they did not trust the health professional. They would disregard advice, seek a second opinion, discharge themselves, rail in anger, or if they were really sick, just withdraw, turn themselves away and refuse to answer questions or minimise their responses. Decision-making preferences turn out to be much more nuanced than the original card sort suggests. A study by Chawla and Aurora in the United States, reported in 2013, recruited over 600 cancer survivors and surveyed them about their follow-up care, their decision-making preferences, their trust in health professionals and self-efficacy. They found that most people preferred shared decision-making, but 22% preferred physician control. When they examined this particular group, they found that they had a greater trust in their physicians and similar self-efficacy, so they were still interested in shared decision-making and able to engage in shared decision-making, but because they trusted their health professional, they were happy for the health professional to make decisions for them. Chawla and Aurora concluded that approaches to decision-making and engagement should encourage patients to participate in ways that they were most comfortable, fostering trust and clear communication. I found this too. I asked patients to reflect on the card sort every time we discussed a different health professional. Patients may have originally said that they preferred to make a collaborative decision, but indicated for specific health professionals with whom they had established relationship, they trusted them to make decisions for them. They didn't see this as a change from their original decision card selection, because who actually made the decision was much less important than the collaborative process, where they were given information, had a chance to ask questions, and the health professional knew their values and the impact of the decision on them as a person. But back to Stella. I don't believe that her health professional intended her to feel dissatisfied with the process of decision making. The health professionals I interviewed all believed that they were very professional and generally supported collaborative decision making. In my postdoctoral studies, I focused on the idea that because patients found some health professionals very skilled at involving them in decisions about their care, and some were not, that there must be a skill set that we could focus on to educate health professionals and to measure their success. I did some in-depth interviews of a group of experienced patients and family members. I asked them to describe the skills of different health professionals who they felt involved them in decisions about their care, and contrast those to the lack of skills in health professionals who didn't involve them. All the patients and the family members were clearly able to identify health professionals with whom they collaborated in decision making, their preference, and those who did not collaborate. I analysed these interviews and came up with a list of proposed skills. I shared this list and then interviewed some health professionals with at least 10 years postgraduate experience, mostly from the palliative care and oncology areas across Australia. I did this on the phone. They refined the characteristics associated with these domains, but they agreed with the skill set and didn't identify any new domains of skill. There were 8 domains, each with a number of characteristics, and they map reasonably well to what is expected of professionals in providing person and family-centred care. I also asked the health professionals how they learned these skills. They were almost unanimous in identifying 4 important strategies: role play, experience, reflection, and supervision. So the tool that was developed is called the Involve Skills Assessment Tool. We have tested the face validity at a workshop of 50 health professional educators and palliative care professionals. We've also done extensive validity and reliability testing, but the results of this are yet to be finalised. We've used it in high fidelity simulation, teaching nurses and health allied health students about discussing bad news with patients, but I also expect it could be used in clinical education and training and quality improvement. So at this point in my narrative, we've identified that patients expect what patients expect of health professionals in terms of person and family-centred care and shared decision-making, and how health professionals develop the skills required. To date, I don't think what I've proposed is necessarily surprising. I have explored how the skills of health professional might impact on shared decision-making, but in the face of skilled health professionals, it still sometimes fails. So let's go back to the Bath family. Without suggesting the Bath family have incredibly bad luck or are plagued with poor health, I want to turn attention now to John. It might be some years later or just an alternate scenario. But for the sake of the story, let's assume that Stella has recovered and life has returned to some sort of normal. John is 62 years old and has not been very well over the last 3 months. He has a persistent cough and after 3 months still not feeling well. Without a regular general practitioner, he went to a walk-in clinic and the GP there treated him for bronchitis. However, his condition did not improve and after another month, he was feeling so unwell he couldn't work. He saw another GP at the same clinic and was sent for a chest x-ray. Although he was a little worried, he didn't discuss it with his wife or children because he didn't want to worry them if it was nothing. He waited for a call back from the clinic. When this came, he was referred for a bronchoscopy. This time, his wife went with him, but he had been dismissive of her concern as fussing, saying that this was just a test. He waited for a call about the results, but when none came, he thought it must be because it was okay. The results were not okay, and it was not until a concerned respiratory physician contacted the GP about his missed appointment that he was contacted and asked to see the respiratory physician. He had avoided telling his wife that he was going back to the doctor since he was now feeling a little scared. He was not feeling well and there were specks of blood in his sputum. The story of delayed treatment and failure to engage in health services in serious illness happens for many reasons, and I want to explore the possible reasons related to John and his hypothetical capacity to engage in shared decision-making. John is fairly typical of older men in Australian society. Not that old, 62. They are less likely to see the GP than women, less likely to have a regular GP, and more likely to be stoic, putting up with symptoms for longer than women, though I'm really not sure how this accounts for man flu. If John is a rural man, these factors are particularly relevant as there are less health services available. But are these the only factors? I did a quick review and found at least this list represented in 3 papers. All 3 papers have made some link between preferred decision role and the factors affecting it. The cohorts examined are patients with rheumatoid arthritis, parents in paediatric clinics and primary care patients. Health literacy was identified as an issue affecting shared decision-making in all of the studies, in addition to other factors like education, age, ethnicity and trust in health professionals. Having a regular doctor, though, was not linked. So from 3 well-powered studies in the USA, we can assume that health literacy is a major factor in being able to engage in shared decision-making, and other factors may also be important. And if our health system of person and family-centred cares are reliant on shared decision-making as an instrument, we may be failing a lot of people, possibly older, male, less educated people with low health literacy of different ethnicities who don't trust easily. So I can hear at this point you want me to address the elephant in the Bath family room. What about their ethnicity? Yes, it's true that different cultural groups have different approaches to decision making. In my own practice in oncology and palliative care, culture has been a central feature in my concerns about decisions about care having been facilitated. Shared decision-making is fundamentally an extension of respect for individual autonomy. It is a strongly held value in Australian society that individuals are best informed by their own values and therefore best placed to make decisions for themselves about their care. It is a reflection of the individualism so present in our Anglo-Saxon culture. In many other cultures, though, there is less focus on individuals and more focus on collectives, families or communities. I think in my clinical and research work over the years, I have heard many stereotypes of particular cultures and religions. Some South Asian people have told me that illness is family business and families who should decide that survival is the sole focus of attention for the person who is ill. Any talk that is negative takes attention away from that sole focus. I've been told by Southern European families that telling a patient the truth will undermine a patient's will to live. I've also been told by patients from these same families and from similar cultural backgrounds that their family members do not understand their needs and they should not be told what's happening to them. In the absence of a father amongst my students from the Middle East, the oldest son often seems to be responsible for healthcare decisions for his family, including unmarried siblings, no matter what their age, mother or other wives, in addition to their own wife and children. Amongst Asian families, it seems not uncommon that an unmarried daughter is responsible for care, although not always care decisions. I've also noted that in serious illness, particularly terminal illness, cultural observances can be important to patients and families, particularly food, place of care and family engagement. One of my students investigated some of the issues Chinese people experience in accessing palliative care services in Australia. She found almost universal horror of Australian hospital food. Not just concern about taste, though I've heard that is a problem, not at Cabrini of course, but the lack of attention to the right type of food being available. To her participants, the provision of cold food to a person who was ill was a failure to acknowledge the need to balance heat in the body of an ill person. Traditional medicines can also be important and represent a commitment on behalf of the ill person and family members to the person's health, despite that they may be contraindicated with Western medicines. Place of care can also be critically important. Our preoccupation with death at home is not shared universally. For some cultures, if the death occurs in the home, or at least the room, becomes uninhabitable. In Australia, we are fortunate to have healthcare systems that allow for personal care of patients, but in many countries, personal care of patients is undertaken by the family, 24 hours a day. Some family members expect here that that will be their role, and is in fact their duty. So back to the Bath family. John's condition has progressed and he's an inpatient, and decisions are being made about his treatment options. He's quite unwell and although conscious is breathless and finds it difficult to concentrate. His wife is distressed and fussing around the bed. John Jr. arrives and is horrified to find his father so unwell. His mother bursts into tears and speaks rapidly in her native Chinese. John Jr. speaks to the healthcare team about the treatment decisions. So yes, this time the Bath family are of Chinese heritage. So if they are Chinese and John Jr. is the oldest son, he's probably making decisions on behalf of the family. Well, not necessarily. With thanks to one of my Chinese students, Kelly Gong, who recently reviewed this literature, if you remember the decision roll cards that I mentioned earlier, they've been translated into Mandarin and Cantonese and validated in a large sample in China. In the Chinese version, another clause has been added because in a Chinese Confucian culture, there is a view that individual reflects the views of their family and is an example, their family is an example of the perfect Chinese community. In the use of this scale, most Chinese authors have indicated all the options include family member engagement. So even if a person prefers an active role, as in the first option, they would have consulted their family. Chinese authors also agreed that patient involvement in the process was high, although others family in up to 40% of cases or the doctor in up to 40% of cases made the decision. So maybe with the Bath family, there is a 40% chance that John has a preference for leaving the decision making up to his family. But do ethnically Chinese families who are raised in Australia with oddly anglicised names hold Confucian beliefs about medical decision making? Is that what is happening to this family? We don't know. What if they were an ethnically Mediterranean family or an Eastern European family who lived in Australia? We simply don't know, unless we ask. Family-centred care requires that we get to know the family, their decision roles, cultural preferences, practices and needs, their language preferences and needs, their health literacy, relationships, communication. If we did this on a regular basis, it might help with the next problem. Culture aside now, let's introduce Barbara, John's beloved daughter. She is Stella's daughter too, but mother and daughter are often at odds with each other. Barbara lives in Sydney. She is both clever and successful in a biomedical science field not related to her father's cancer, but she does have some understanding of the disease and has researched the treatment options for him. She arrives like a whirlwind. Stella and John Jr. appear pushed to the edges of the room as she rushes in. Although he cannot speak, John's tired face lights up when he sees her. The arguing starts about an hour later. Barbara wants John to be moved to a hospital in Sydney where she believes he will be able to access a new trial of a drug he has not tried. Stella and John Jr. believe he's too sick, and they trust the health professionals now caring for him that if the trial was promising, it would have been offered. John Jr. has been at his parents' side constantly throughout the illness, and he believes that his sister is consistent in that this is just another attempt to control the family by turning everything upside down at the last minute, that she would have come to Melbourne earlier than this if she'd really cared. Unfortunately for all of us, serious illness brings out both the best and the worst in our families. Sometimes we see families pulling together, overcoming personal issues with each other and working together with extraordinary sensitivity for each other. But for others, serious illness is like the final straw in already strained relationships. In most of the literature I've seen about conflict in families, the issues are about disagreement with health professionals and how these are resolved using a local and eventually authoritative ethical and legal approach. In my practice, I've also seen disagreement between family members, with the patient and the health professionals somewhere in the middle. The risk, of course, is that in this case, the loudest and most threatening voice will somehow be the one that is listened to, and family members fall into roles that they have always undertaken. So John Jr. capitulates and withdraws. His mother dissolves into bullied passivity, and John Sr. is prepared for a move that doesn't happen because he's dying. The family is irrevocably disenfranchised by the experience, and their bereavement prolonged and complicated. Often conflict in a family about what should be done for a patient can no longer engage in decisions about their care is the basis of disagreement. There may be different views about the patient's values and the decisions he or she may have made had they been able. So in this case, where conflict is about decision making, what do health professionals do? If you do not have an appointed medical treatment decision maker or one that's not been appointed by VCAT for you, the first person 18 years or older in the following list is who your health professionals go to as your medical treatment decision maker. They must be reasonably available and willing and able to make the decision. So your spouse or domestic partner, your primary carer, your adult child, your parent, your adult sibling. If you have two or more relatives who are first on the list, it is the eldest person. So if Stella is not able to be this decision maker, then it's one of the children who are responsible. Either way, the conflict in this family will not be lessened. One of the most useful strategies Sorry, that's gone back. One of the most useful strategies that appears in most of the studies about family conflict resolution is the interdisciplinary family meeting, commonly used in ICU, paediatrics and palliative care settings. In palliative care, Peter Hudson and colleagues from St Vincent's Hospital and Melbourne University's Centre for Palliative Care have developed and tested guidelines for the family meeting. They emphasise a set of very detailed steps for running palliative care family meetings. The use of family meetings is identified on admission for patients and a standard tool for decision making and support of family members. So then it's a matter of preparing for the meeting by understanding the family relationships and dynamics in order to recognise who might need to be a part of the discussions and particular issues. The staff selected to chair and attend the meeting will depend on the issue, but the use of a skilled facilitator for a meeting where conflict is present will be important. The conduct of the meeting is undertaken with ground rules about who speaks and when, and a respect for all present, by involving all of them in the discussion. The documentation and follow-up from these meetings is important to ensure patient and family found the meeting helpful and are still comfortable with the outcomes. One of the most important actions a person can take in relation to future-proofing their medical decision-making is appointing a substitute decision-maker, having discussions with them and, if necessary, writing advance directives. In Victoria, new legislation in place just last week has reaffirmed these decision processes and protected them in law. Substitute decision makers are appointed by a person to make medical decisions for them if they're unable to be involved. The idea is that this appointed person makes decisions as if they were the person, from the person's perspectives rather than purely from their own. We've been asking people on admission for some years if they have appointed an enduring power of attorney medical treatment, if you've gone to get your will done with a lawyer in the last 5 years or more, you would have been asked if you would like to include the appointment of such a decision maker. Legally, this is a relatively straightforward task. So we do one, and then we forget it. We forget to have the conversations that inform this person that what our values and our treatment preferences might be. We forget to discuss the appointment with the rest of the family, getting them all on the same page. The document making the appointment and the advance directive that we so carefully prepared sits in the safe deposit box at the bank with our will, the title to the house and grandma's jewellery. This means that the in-hospital experience of substitute decision makers is often difficult. This 2012 publication, a much earlier study in ICUs in France, interviewed relatives 90 days post-death or discharge of a patient. They looked at 3 measures: the impact of the event, which measures indicators of post-traumatic stress disorder, the general health scale, and anxiety and depression. They found PTSD a common reaction 6 to 9 months after death or discharge, and this was strongly associated with being a substitute decision maker. Also, they noted a lack of information, not feeling welcome in the unit, and communication difficulties with staff. Because I'm unclear about the law or practices in ICUs in France, I looked for similar literature in other jurisdictions. There have been similar studies in the US and the UK, some associating the role with complicated grief. We have also recently completed a review of qualitative studies on the impact of decision-making for people with dementia, and found 7 studies from around the world that investigated how substitute decision makers were affected by making decisions for people with dementia. They indicated that trust in healthcare personnel positively affected substitute decision makers and supported their adaptability. However, substitute decision makers also experienced guilt, mistrust and confusion as they encountered increased complexity in care, increased health interventions, and as social needs changed. Substitute decision makers experienced complexities and struggled to interpret quality of life and negotiate end-of-life treatment decisions. They also had practical needs in relation to negotiating with family as they fulfilled their support roles. In addition, ambiguity in advanced care plans, limited knowledge of dementia and end-of-life uncertainties and communication issues reduce the ability of the substitute decision maker to be proactive. The substitute decision maker role is a complicated one. I know, I've been one. My mother appointed me her power of attorney. My family were all on the same page. Nevertheless, it was stressful playing the go-between my mother, the health professionals and my siblings. I understood the health systems and had some knowledge of her disease process and the care options, and I knew her wishes. I felt comfortable speaking plainly to health professionals, yet it wasn't smooth. People forgot to read the documents. I missed some of the key players, and decisions were made when I wasn't there. I cannot imagine what it might be like for the Bath family, negotiating culture, language, conflict, and an unfamiliar health professional environment. So if we accept that the role of substitute decision maker is complex, what training and support is there out there for those taking on this role? I'm sorry. There's precious little. There's little research or models of support or evidence for based training for substitute decision makers. So we need to develop these. Some instruction on the scope and nature of the role of making decisions on behalf of another person. Providing them with some guidance as to how to have those discussions about values and end-of-life wishes. How to manage talking to family members, how to talk to health professionals, how to navigate health systems, general and specific information about health conditions, treatments and outcomes. We need to provide decisional support as we would for patients, decision aids for example. We also need systems for providing follow-up care and support for substitute decision makers to reduce potential anxiety and regret. So you'll be relieved to know I finally come to some concluding remarks. Person and family-centred care are the very fundamentals of healthcare decision making. If we believe that shared decision making is important for our health services, we must be person and family-centred. The cost of not sharing decision making with patients and their family members is dissatisfaction, poor care and poor outcomes. In addition, for health services, higher costs, health professional stress, burnout and dissatisfaction with care. Although we would be wrong to assume that the majority of people wish to make their own healthcare decisions, we should be careful about assumptions that most people want to collaborate with health professionals or share decision making with their family. Shared decision making should be treated in the context of understanding a person's values regarding their healthcare, their culture, their language preferences, health literacy and family roles. There are tools that can help here. Interdisciplinary family meetings and advanced care planning are but a couple. Nevertheless, there is more work to do, particularly in understanding how culturally and linguistically diverse families would like to be supported in decision making and in preparation and support of substitute decision makers. Thank you for indulging me this evening. I hope this has served to inform and leads to a more attention about how person and family centred care might be improved in our health services.
Don't go far because there might be some questions. I'll open up to questions in the audience. Anne's got a microphone. Yes, there's one over there, Anne.
Hello, Mark Silver. I'm social worker with the Community Dementia and Cognition Program. Look, thank you very, very much for a marvellous presentation really about family and family dynamics and cultural issues and all the things that really, really matter around family-centred care. I was just wondering what research there is around the professionals themselves. You mentioned the health professional team. Well, obviously, you know, there are also social workers and counsellors involved. Very much, Cabrini is very proud of that, having a tremendous team to support the decision makers and the conflicts that exist. And I'm just wondering whether there's any research around the kind of composition of the team and the use of those kind of professionals in terms of the outcomes that you've found through your vast experience?
I'm sure there is. Because my area is focused mainly on palliative and end-of-life care, which is essentially interdisciplinary in its nature, and my other focus is around nurse education, the areas of counselling aren't an area that I've really focused on. But there certainly is literature in palliative care that emphasises the importance of that interdisciplinary approach. Probably it's where that research is at its strongest, is in palliative care.
Thanks, Susan. That was really great, and it was great to hear people speak the language that we understand and share. I was going to ask you really about how important do you think communication theory is in terms of trying to get people to learn shared decision-making education processes. So I'm aware of Hudson's paper. It's a great paper. But there are other communication styles papers that talk about the style of questions we ask, whether you ask direct questioning or circular questioning, how you achieve congruence in decision-making, what we describe as triadic congruence, patient, caregiver. So sometimes I think that the challenge with teaching communication skills or teaching models like this is it's easily forgotten because the theory is not taught. So trying to get somebody to play the piano without teaching them how to read music as
Absolutely.
such. Yeah.
Absolutely. I think part of that is about the discussion about health literacy, that we can't expect a person who has no background in health, no health training, to be engaged in healthcare decision making as if they were a health professional. And yet for substitute decision makers, that's sometimes what it feels like. That all of a sudden you're not treated as the voice of the patient, you're treated as someone who should know, who should just know about everything. And that's often not the case. Often it's a partner, it's a sibling, it's a child who may not have any training in healthcare. So I think the starting point is communication. It's understanding the elements of health literacy. So that means we've got an enormous amount of work to do. Not just our health professionals, but also the community.
Just to follow up to that, in a clinical setting, how do you think it's best to measure different elements of health literacy, which is looking at different tools, might have multiple domains? What do you recommend?
I don't have a particular health literacy tool that I would recommend, but there are definitely ones that the national standards in health and quality recommend for investigating health literacy. So that's where I would probably start.
Right. I think it's the end of it. One more. One more.
Some information in the press lately about the amount of time that a person stays in hospital after an operation. That may depend, of course, on the severity of the operation, but it would suggest that the longer a person, or the 2 or 3 days after that, they're in after the operation, then there is less infection, there is less readmission and so on and so forth. On the other hand, it would seem to me that family-centred care, the sort of thing you've presented, very much comes into that decision-making of how long a patient stays in hospital other than just a clinician saying you're okay or whatever, or to some extent the amount of health insurance, cover pro rata and all that sort of stuff, payment you have to make. So it seems to me, and I think Cabrini do this, that it is possible to get support in the home, even if the stay is short, but the family care situation must vary so much according to culture and all those other things you've suggested. Have you got any advice to give to people on who should make the advice other than the clinicians or the hospital system or the health insurance company as to the length of time a person stays in hospital, bearing in mind, of course, that infections are rapidly caught in hospital settings too, and it's better to get out as fast as you can. Have you any thoughts on that?
This is very much Lee's area of expertise, more than mine. My understanding is that the length of stay is standardised from work that's been done over many years, collecting cases and understanding average lengths of stay. Of course, there would be always differences in public and private. I think without having the research at my fingertips about this, I think community services are underutilised. And the more they're underutilised, the more they can be cut back. So we should be using them more. We should put more demand on the community services so that we maintain that service into the future. And discharge planning is absolutely critical in terms of ensuring that the family care for the person who's returning home is there and that it's functional. So in the public sector, at the very least, it's one of our major problems with readmission is that work isn't done, and so the patient bounces back because they don't have the care at home. And of course that's a terrible waste of resources, and also is a terrible amount of suffering, additional suffering that we place on families and patients. And it's a terrible place to be in as a family member who's not doing it right. It really is an awful place to put a family member in, is to push them into a position where they're not going to be able to manage.
But there is, of course, support from OTs and social workers.
There are absolutely many services that work for patients in helping them to get home, but also many services available in the community, like interdisciplinary services in the community that will help a person to stay at home.
I'm wondering if I could ask Natasha to respond a little bit, because we have a suite of services here that are a really important part of family and patient-centred care.
I think one of the things we have learned in palliative care is how important it is to train the family to care. So we have quite a successful discharge and readmission planning, readmission prevention rate in our home care service. And what we've done is we do trials of care. So if families want to go home, we ask them to come in, and the beauty of Paran is it's built like a home. And we say you pretend that you're at home for the day. And you're going to do all these things for your mother or your father, and we're going to watch and instruct you. And it's been one of the most effective things, really, and it allows us to address issues on the spot then and there, and responsiveness. And I suppose we have the privilege of being able to manage our budgets within our constraints here, which sometimes is very difficult for the public sector to do.
Yes, I agree.
But it's something I've really realised, how little we train family members on how to care in the community. I don't know if I've answered the question.
Yeah. Yes, Darren.
As a health professional, kind of two parts to the question. At what point in the getting to know the client do you find out about their desire for collaborative or passive or active management, and do you have kind of a shortcut script that's proven that you can kind of use as key questions, get that information, and at what point would you get that information?
I think that any self-respecting patient or family member would see through the script in a second. It's all about relationship, and that relationship building has to happen in the first few minutes of a consultation. So,
no pressure.
No pressure at all. First 5 minutes, I think, is about the maximum amount of time you've got to get that bit right. So if you don't get that bit right, then you can ask them what style of decision making they'd like to have, but you're not going to get any sense of what they'd really like to have, just what they might have with you, because they don't really like what they're seeing so far. So it probably needs to start with relationship and building that sense of trust, and really you need to ask about their preferred decision style before decisions are made. So it's no point asking them about their decision styles further once the decisions have been made, because generally from the patients I spoke to, it was that first decision that they carried with them the most. And many of them talked about unsatisfactory diagnostic experiences, when they heard their diagnosis for the first time, but I also heard lots and lots of really wonderful examples of great communication. I'd probably have to go back and reanalyse it to determine what the script might be, although it's probably more what the principles might be of that initial approach. They are things like making eye contact, having, not just carrying the history under your arm, although we don't do that anymore because it's all online, but having read it, knowing what the background of the person is, so that when you're talking to them, they get that sense of that you know who they are. So those sorts of really basic communication 101 strategies that we try and teach health professionals at the beginning, that building rapport stuff, is critically important.
Thank you. Thank you very much. All right, I'd just like to give you this little gift and say thank you very much.
Thank you very much.
All right, I'd like to just thank Darren for his 17 years of fabulous friendship to Cabrini, to the Cabrini Institute and to our Cabrini nurses. The difference it makes, the scholarships we put through oncology nurses, we get postgraduate coursework up and going with these scholarships, and it makes a real difference to patient care, in my opinion. I'd like to thank our Cabrini donors and our friends for their continued support of this important event tonight, and I'd like to flag that it is National Advanced Care Planning Week from the 16th to the 22nd of April. There's lots of exciting changes that are underway at the moment, and we have a desk out the front here where you can learn about the Medical Treatment Planning and Decisions Act, everything you wanted to know. And the Advanced Care Directive piece with Michelle Speak, who looks after this area for us. I'd also like to remind you that on your chairs there is a brochure about the Peter Meese Memorial Fund, and should you wish to contribute, you're able to do so. There's some information about that there. And we would now like to invite you to share some stories, to ask some questions, and to join us for some refreshments in the foyer. Thank you so much for your time this evening.